Now we have finished with the general pharmacology. Now we are going to start with the systemic pharma. Since these are easier chapters, we are going to breeze through each of them, and we are going to do the MCQs of all these 4 chapters after the respiratory system. Okay, so starting with autocoids. Autocoids means they act locally. Local, it is acting locally. There are amines, peptides, lipids in all of these in the autocoids. First we'll start with amines. These are histamine and serotonin. Now histamine related drugs. Histamine, when it activates the H1 receptor, it will cause allergy. So to treat this allergy, we will give H1 receptor blockers. H1 receptor is also responsible for wakefulness in the body. So if you block this H1 receptor, it will cause sedation, isn't it? So antihistaminic drugs will cause sedation. That is why when you take a cetirizine tablet, you feel sleepy, isn't it? So we'll see. First we have made antihistaminics. They used to cross the blood-brain barrier and it will cause sedation. These are first generation. So we try to make other class of drugs which are not crossing the blood-brain barrier, so it is not causing the sedation. These are known as second generation antihistaminics. First we'll do antihistaminics that are in first generation. Even though these are antihistaminics, it has maximum anti-muscarinic effect. So these are used in conditions where anti-muscarinic drugs are required. Example, motion sickness. What is the drug of choice? Scopolamine. Example, drug-induced Parkinsonism. What is the drug of choice? Benzexol. Let us suppose if scopolamine and benzexol are not available in this condition. What can you give? You can give first generation antihistaminics like promethazine, diphenhydramine and dimenhydrinate. Promethazine, diphenhydramine and dimenhydrinate. These can be given in motion sickness and drug-induced Parkinsonism. Why? Because these have the maximum anti-muscarinic effect. Maximum anti-muscarinic effect. Did you understand this much? So these are used in drug-induced Parkinsonism and motion sickness. Now, can you give this in our patients? Can you give this in people who requires a lot of attention? Think about it. Since they are crossing the blood-brain barrier, they will cause sedation, so you cannot give it. So these are contraindicated in pilots, drivers, especially heavy vehicle drivers like lorry drivers and students. Did you understand? So first generation antihistaminics we are not using in allergies, we are only using it in motion sickness and drug-induced Parkinsonism. Coming to the second generation, these don't cross the blood-brain barrier, so it is not causing the sedation or lesser sedation. That is why these are preferred antihistaminics. Therefore, these are drug of choice in urticaria. Okay. Examples. Cetirizine. See, cetirizine comes from a derivative that is known as, cetirizine is a derivative of hydroxyzine. It is made from hydroxyzine. Hydroxyzine is a first generation antihistaminic. That is the reason why cetirizine still has sedation even though it is second generation antihistaminic. That is the reason why we have made levocetirizine. Levocetirizine is less sedative than cetirizine. Now, what is the least sedative drug of all? It is fexofenadine. I told you, second generation antihistaminics are causing lesser sedation. But in all of the second generation, which is having the least sedation potential is fexofenadine. Now, other drugs are rupatidine, olapatadine, alcaptidine. See, olapatadine is actually used in something known as VKC, vernal keratoconjunctivitis. Vernal keratoconjunctivitis. VKC. This is allergic conjunctivitis. Did you understand? It is also known as spring catarrh. Now, in the second generation, estimazole and terfenadine are blocked because they can cause QT prolongation. That's all about the antihistaminics. And in antihistaminics, there is a drug called doxylamine. Doxylamine plus vitamin B6 is the drug of choice for morning sickness. Doxylamine plus vitamin B6 is the drug of choice for morning sickness. Now, we have finished antihistaminics. We will start with the serotonin related drugs. Now, why are these serotonin related drugs important? Let us try to see in the chapter called migraine. So, we will talk about migraine first. See, what or how do you have migraine? There are many theories for it. I will talk about one theory here because the theories for migraine are not proven. We have 2 or 3. Yes. So, I will talk about one theory. One theory says whenever CGRP is released, this CGRP will act on the CGRP receptors of blood vessels and it will cause vasodilation. Because of vasodilation, it will compress the meninges and it will cause the headache that you see in migraine. Okay. When it acts on the CGRP receptors present on neurons, it causes neuronal inflammation. So, this is what is happening. Basically, when CGRP is released, it will cause migraine. Okay. Now, fortunately, we have autoreceptors here. If you remember, autoreceptors means brakes. They are present in presynaptic or postsynaptic. I talked about alpha 2. Alpha 2, presynaptic or postsynaptic? Obviously, presynaptic. On presynaptic, we have serotonin receptors like 5-HT1B and D. These are autoreceptors. So, if I activate these receptors, it will block the release of CGRP. It will cause vasoconstriction. It will decrease neuronal inflammation. So, that is the reason why these are used in migraine. Yes. So, what are the first class of drugs? In the acute attack of migraine, we give 5-HT1B and D agonists. Since these are autoreceptors, they will decrease the release of CGRP. What are the drug names? These are triptans. Rizatriptan, sumatriptan, amitriptan, frovatriptan. Yes, all these triptans. Now, there are some other ergot derivatives. They also work the same way. Ergot derivatives. These are ergotamine. Now, problem with these drugs, both of them work the same way, but the problem or side effects. See, 5-HT1BD. If you remember, I told you wherever BD receptors are present, I told you they are present on blood vessels. So, 5-HT1B and D receptors are also present on blood vessels. When these are activated, it will cause vasoconstriction. So, it will cause vasoconstriction in the brain, then it is helpful in migraine. But if it is causing vasoconstriction in other parts of the body, is it helpful to us? No, actually it is not. Why? Because if it is causing vasoconstriction in the peripheries, it will increase the blood pressure. And if it is causing vasoconstriction in the heart, it might increase the risk of ischemic heart disease. So these are the side effects. It can cause hypertension or it can increase the risk of ischemic heart disease. So ergots and triptans can do this. So if you give ergots and these triptans together, there might be severe vasoconstriction and formation of gangrene on the peripheries. This is what is known as ergotism. Can you see here? This is what is ergotism. That is why triptans and ergots are never given together. They are avoided. Now, if you understood this much, this is about 5-HT1B and D receptors. These are autoreceptors and they are also present on the blood vessels. Now, there is one more autoreceptor, that is a new one, that is 5-HT1F. So, if we activate this, same thing will happen. This is a new drug that has been discovered recently, invented recently. This is lasmiditan. Okay. Now, CGRP acts on CGRP receptors, so we can also directly block the CGRP receptors. These are known as CGRP receptor antagonists. These are rimegepant and atogepant. Now, in the acute attack, these are all the drugs you can use. And you can also use NSAIDs like paracetamol and ketorolac if it is a severe attack. If it is a severe attack, what can you do? You can use opioids like butorphanol. Okay. So mild attack you can use NSAIDs. If it is severe, you can use opioids. Simple. So this is about the acute attack of migraine. Now let us suppose a patient has come to you with a mild headache. What would you do? You should start with NSAIDs, preferably paracetamol. If not, then you go to ketorolac. If a patient has moderate to severe headache, you preferably give what? Triptans or ergots, but not together. You can give NSAIDs plus caffeine. It will work well. In pregnancy, what can you do? Obviously, the best drug would be paracetamol. You give paracetamol. If paracetamol is not working, then you can give sumatriptan. Other triptans are not safe in pregnancy, only sumatriptan can be given. But I told never combine triptans and ergots together. Now, drug of choice for migraine prophylaxis, we have talked about this in the first chapter. It is propranolol. So we have finished with the amines. Now we'll see the lipid autocoids. In this, we have to study about the prostaglandins and the drugs inhibiting these prostaglandins. Drugs inhibiting these prostaglandins are NSAIDs. How? I'll tell you. See, in the cell membrane, we have phospholipids. Yes, I told you, every cell membrane is made up of phospholipid bilayer with proteins in it. Now, this phospholipid is broken down by phospholipase A2 and this forms arachidonic acid. On this arachidonic acid, COX enzymes and LOX enzymes will act. When COX enzymes act, it will release this prostaglandins. So, if you block this COX enzymes, this prostaglandins will be reduced. These are known as NSAIDs. Why are we blocking this? Because prostaglandins can cause inflammation. Now, if you block this phospholipase A2, these are known as steroids. So, steroids will block the entire pathway. So, the best inflammatory drug is steroids. Next is NSAIDs. NSAIDs only block COX. That is why these are known as non-steroidal anti-inflammatory drugs. Steroids are steroidal anti-inflammatory drugs. NSAIDs are non-steroidal anti-inflammatory drugs. That's all. So, first we'll see about prostaglandins and what they are doing in the body. Now, prostaglandins are several types. First, we will see there is prostaglandin E. So, we try to make prostaglandin analogs like prostaglandin E1 analogs and E2 analogs. Prostaglandin E1, there is misoprostol. Misoprostol is actually used in the first trimester abortion. This is the drug of choice in the first trimester abortion because it contracts the uterus. Misoprostol is also specific drug for NSAID-induced peptic ulcer. NSAID-induced peptic ulcer. Why? I told you, prostaglandins are gastroprotective. If you give NSAIDs, they will block this and it will cause the peptic ulcer. So, how can you treat it? By increasing these prostaglandins. That is why we are giving the misoprostol. Why am I saying specific drug but not the drug of choice? Because drug of choice for any peptic ulcer disease is proton pump inhibitors. Good. Now, alprostadil, it is given in the name DIL, so it must act somewhere on the heart. So, it is helpful for keeping the patency of PDA, patent ductus arteriosus. Patent ductus arteriosus usually closes after the childbirth. Yes, to keep it open, we can use alprostadil. Now, next is PGE2 analog. This is dinoproston. This is the drug of choice for cervical ripening. So, E is finished. Next is F. Prostaglandin F2 alpha analog. In this, the most important one is latanoprost. Latanoprost is the drug of choice in open angle glaucoma. What is the drug of choice in closed angle glaucoma? It is pilocarpine. What about open angle glaucoma? It is latanoprost. Latanoprost is prostaglandin F2 alpha analog. Now, Dinoprost and carboprost can be used in abortions. Carboprost can be used in PPH. Now, coming to PGI2 analogs, this will study when we are studying the pulmonary artery hypertension chapter. Yes, these drugs can be used in pulmonary artery hypertension because they will cause vasodilation in the pulmonary arteries. Okay, so these are the prostaglandin analogs. The most important one is misoprostol, prostadil, and the next one I wanted to remember is latanoprost. Now, what are the side effects of latanoprost? They will ask you. You can remember PGF. P means pigmentation of iris. This is also known as heterochromia iridis. G is growth of eyelashes. It will increase the growth of eyelashes and it will cause fluid in the eye, so it will cause macular edema. These are the side effects of latanoprost commonly asked. Okay, now in the abortion I told you, in the first trimester what do you give? In the first trimester you give mifepristone plus misoprostol. First you give the tablet of mifepristone. Why? Mifepristone is it is given in the name PRIS. It is a progesterone receptor antagonist. So it will cause detachment of the embryo and you have to cause contraction of the uterus by giving misoprostol. Now second trimester, what can you use for the abortion? You can use dinoprost, carboprost. All of these are used in the second trimester, but according to the gynecology textbook, they say here also misoprostol is used. So that's all about the prostaglandins. Now coming to the NSAIDs. NSAIDs are COX inhibitors. So they are decreasing the production of prostaglandins. So they will decrease the inflammation. They will decrease the fever. So that is why whenever you have fever, you take paracetamol as an NSAID. Okay. So first let us see paracetamol. What is the drug of choice for paracetamol toxicity? If you take a lot of paracetamol, it will damage your liver. Now, when the liver is damaged, what or how it is damaged? It actually decreases the glutathione level, so it will cause free radical injury. Now, to prevent this, you can give N-acetylcysteine. N-acetylcysteine. I already told you what is the side effect of paracetamol poisoning. It is hepatotoxicity. Yes, how can you predict this hepatotoxicity? By something known as Rumac-Mathieu normogram. Rumac-Mathieu normogram. Yes, now coming to the aspirin. Aspirin is an antiplatelet drug. Yes, true. It is an antiplatelet drug. It is also an anti-inflammatory drug as well. But what is most important to us are the side effects. Aspirin can cause bleeding. Aspirin can cause race syndrome. It can cause Samter's triad and it can also cause hyperuricemia. Yes. Now, what is race syndrome? Let us suppose a child is recovering from viral illness, viral flu or something, and if you give aspirin in this patient, it will cause hepatic encephalopathy. This is what is known as race syndrome. Okay. Now, what is the drug of choice for aspirin toxicity? I told you, aspirin is a acidic drug. So you do what? Forced alkaline diuresis. If no response, obviously you will do hemodialysis. This is what I told you. So these are the two important NSAIDs I want you to know. And these NSAIDs will block both COX-1 and COX-2 inhibitors. So because of this, it will cause a side effect. It will cause a side effect that is peptic ulcer disease. Because COX-1 is protective. So we have made a drug that is known as selective COX-2 inhibitors. So these are also known as COXIBs. They will not block COX-1. That is the reason why they don't cause peptic ulcer disease, but they cause cardiotoxicity. So what are the drugs? Etoricoxib, celecoxib, parecoxib. These are selective COX-2 inhibitors. Okay, but they are causing cardiotoxicity. That is why reficoxib and valdecoxib are banned, because they have caused cardiotoxicity. Did you understand? So the other ones are non-selective COX inhibitors. These selective COX-2 inhibitors can cause cardiotoxicity. Now, if you want to close the patent ductus arteriosus, which NSAID can be used? Because I told you, if prostaglandin E is present, it will keep the ductus arteriosus patent. So how can you decrease this prostaglandin? By giving NSAIDs. So NSAIDs can cause closure of patent ductus arteriosus, isn't it? Which NSAIDs? There are two. You can give indomethacin or ibuprofen. The drug of choice in India is ibuprofen. In India is ibuprofen. Okay. Now, what are the side effects of these NSAIDs? It can cause hypersensitivity reactions, peptic ulcer disease, and nephrotoxicity. This much you know. Everybody tells you painkillers will damage your kidneys. Yes, yes. Now, NSAIDs should not be used together with ACE inhibitors because of hyperkalemia. This has been asked in the recent FMGE exam. Why NSAIDs will decrease prostaglandin? Because prostaglandins usually cause increased GFR. If there is decreased prostaglandin, there is decreased GFR. So filtration is reduced. So sodium and potassium stay inside the body. If potassium is staying inside the body, it will cause hyperkalemia. ACE inhibitors will also cause hyperkalemia. That is why both of them cannot be used. If you use both of them, it might cause hyperkalemia, they might cause arrhythmias, the patient might die. That's all about the NSAIDs. Now, coming to the easier chapter, that is about the gout. Gout, in the acute attack, what is the drug of choice? First, let us see what is gout. Why is this gout happening? This happens whenever there is increased uric acid. If the increased uric acid is in the blood, we call it hyperuricemia. Now this uric acid will go and deposit in joints and other areas. If it deposits in the joint and causes inflammation, this is what is known as acute gout or acute gouty arthritis. Why? Because in the joint it is causing inflammation, redness, pain, swelling, all of this. How do you treat all of this? I told you. How do you treat inflammation? By giving NSAIDs. So the drug of choice for acute attack of gout is indomethacin. If indomethacin is not working, if there is no response, you can give colchicine. If colchicine is not giving any response, then what can you do? You can give intra-articular steroids. Why? Steroids are the best anti-inflammatory drugs. That's all. This is about the acute attack. Now, why is this acute attack happening? Because of hyperuricemia. So, in chronic attack, what is your aim? To decrease the uric acid. How is uric acid formed, you ask? How is it formed? Think. Let us suppose you're eating too much of meat or whatever it is. If the cells are being broken down, cells are made up of purines and pyrimidines, isn't it? When these purines and pyrimidines are broken down, they are forming xanthines. From these xanthines, you have uric acid. Now, which enzyme is converting these xanthines into uric acid? It is xanthine oxidase. So, if you block this, will uric acid be formed? No. So, xanthine oxidase inhibitors are the drug of choice for chronic attack of gout. That is what is allopurinol. If allopurinol is not working, you will give febuxostat. So, which drug can be used for prevention of uric acid formation? That is allopurinol and febuxostat. Drug of choice for chronic gout is allopurinol. Now, let us suppose there is already lot of uric acid in the body. How can you treat this? Lot of uric acid. Will you give allopurinol? If you give allopurinol, it will stop the formation of new uric acid. But what about the present uric acid that is already in the body? What will you do for this? Think. There is a condition that is known as a tumor lysis syndrome. What do you mean by tumor lysis syndrome? Tumor means overgrowth of cells. There are a lot of cells. There are a lot of cells in tumor. When you give chemotherapy, all these cells are dying. If all these cells are dying, purines and pyrimidines in these cells will come out. They will be converted into uric acid. There is a lot of uric acid now. Now you cannot use allopurinol to decrease this uric acid. What will you do? See, in the birds, uric acid is converted into allantoin by uric acid oxidase enzyme. This is also known as uricase. So what did we do? We tried to make a uric acid analog, that is what is uric acid oxidase analog, that is what is known as recombinant uricase. The answer is pegloticase. That is the reason why we use pegloticase in tumor lysis syndrome. Did you understand this much? Now, there are some other uricosuric agents, that means it will increase the excretion of uric acid from the kidney. Examples are probenecid, sulfenpyrazone, benzbromaron, lesirinide. But these are not commonly used because whenever there is uric acid going into the urine, it will cause stones. This is about the gout. I want you to remember acute attack, indomethacin. If it cannot be used, colchicine. Colchicine will cause a peculiar side effect, that is, it will cause intractable diarrhea. Lot of diarrhea, severe diarrhea. That's all. For chronic attack, allopurinol. If it is not available, febuxostat. In tumor lysis syndrome, you use pegloticase. But to prevent the formation of uric acid, it is allopurinol. Okay. Now, the last one, this you will study in the medicine. Rheumatoid arthritis. What are you going to study? This is a what? It is an autoimmune inflammatory polyarthritis. This will cause deformities if it is not treated properly. Now, how can you treat them? Obviously, whenever there is an acute attack, you try to treat it with the NSAIDs. But the problem here is inflammation. How can you stop the inflammation? Obviously, by steroids you give. Okay. Now, can you actually treat this disease? Can you actually decrease or stop the disease progression? See, you cannot stop the disease progression, but you can decrease the disease progression. This is done by something known as DMARDs. These are disease modifying anti-rheumatic drugs. That means the disease process will continue. We can only slow it down with the help of DMARDs, disease modifying anti-rheumatic drugs. But these DMARDs will take 3 months to show effect. Till those 3 months, we use corticosteroids. That is why we call this bridge therapy with corticosteroids. So, we are giving DMARDs along with corticosteroids for the first 3 months. Yes. What are these DMARDs? These are the 4 things that we generally use. We either use methotrexate, hydroxychloroquine, sulfasalazine, or leflunomide. Methotrexate is also drug of choice in choriocarcinoma. Methotrexate, the most common side effect, it will cause hepatotoxicity. Now, coming to hydroxychloroquine, it comes from a drug that is known as chloroquine. Chloroquine has a very high volume of distribution. In fact, this is the highest. Its volume of distribution is more than 15,000 liters. So it goes into all the tissues and it will cause side effects in all the tissues. In the eyes itself, it will cause vortex keratopathy in the cornea. And the most important one I want you to remember is it will cause a bull's-eye maculopathy. Bull's-eye maculopathy, vortex keratopathy. Yes, posterior subscapular cataract, many things it will cause. But this is the safest DMARD in pregnancy. Next, sulfasalazine is contraindicated in G6PD deficiency. Leflunomide side effect is hepatotoxicity and megaloblastic anemia. You study it in a lot of detail in internal medicine, but I am just telling you the drug names. Okay. Coming to the biologics, what we usually do, this rheumatoid arthritis is happening because of some agents like TNF alpha. So we are giving anti-TNF alpha like infliximab, adalimumab and golimumab. infliximab, adalimumab and golimumab. How do you do the treatment? You give DMARD along with biologics. Yes, if biologics is not working, you give JAK-STAT inhibitors like tofacitinib and baricitinib. NIBs are JAK-STAT inhibitors. Now, what is the side effect of anti-TNF alpha? This is reactivation of latent TB and it increases the risk of hepatitis B and C. It increases risk of hepatitis B and C. So, that's all. This is the short version of Autocoids. Usually, these are the most important things that are asked from the Autocoids.